Good morning, everyone. I'll be starting. This is Gabrielle Lessard. I am with the National Immigration Law Center. Give me just a moment to share my screen. Okay, it says that you have disabled participant screen sharing. There we go.
Try that now.
Yes. All right, so I will be giving a policy update. A lot has happened since the inauguration, particularly in the realm of immigration policy. So first of all, I'm with, again, the National Immigration Law Center. People generally call us NILC. And our mission is to defend and advance the rights and opportunities of low-income immigrants and their family members. We don't practice immigration law. We try to shape public policy through analysis and advocacy, impact litigation, and strategic communications. So I'm going to start by talking about public charge. Public charge has been part of federal immigration law since the 1800s, but it has historically been very limited. Then in 2019, the Department of Homeland Security published regulations that expanded the meaning and application of public charge. The current administration has allowed the courts in a number of different legal cases to block the public charge rule that was published in 2019. So the prior rules have now gone into effect. But we're still continuing to see the effects of the 2019 rule. Even before it went into effect, it deterred people in immigrant families from accessing health care and other essential benefits, particularly people in low-income families. More than a quarter of adults in low-income immigrant families reported in a survey that either they or a family member had avoided a non-cash benefit program, including Medicaid or SNAP, because they were worried about risking their green card. So a public charge is a person who is primarily dependent on the government for support. And again, the Department of Homeland Security regulations, which actually came from a sub-agency called U.S. Citizenship and Immigration Services, are no longer in effect. So on March 15th, USCIS actually announced that effective the previous Friday, March 9th, it would no longer apply the 2019 public charge rules, and it would go back to some policy called the Interim Field Guidance that was released in 1999. That notice also told people who were in the process of applying to get a green card or become a lawful permanent resident, those are just two different ways of saying the same thing, that they no longer had to submit any information that was required under the 2019 rule. Now, there's some things that are in the law that don't change with the policy changes. So first of all, public charge is a standard for inadmissibility, meaning a reason that a person can be denied permission to come into the country or permission to become a lawful permanent resident, again, also called getting a green card. In the law, there are a number of factors, which are the person's age, health, family status, resources and income, and skills and employment, as well as if they have a sponsor who has executed a contract called an affidavit of support on their behalf, whether their affidavit of support is legally valid. So the Department of Homeland Security is looking at whether a person is likely to become a public charge in the future based on their current characteristics and circumstances. This is called the totality of circumstances test. That's a long term, but it just means that the person who is considering it has to look at everything, and no single factor can determine whether someone is going to be deemed likely to become a public charge. Important to know that there are many categories of immigrants who are not subject to the public charge test. It primarily affects family-based immigrants, people who are admitted to the U.S. on humanitarian grounds, including refugees, people granted asylum, survivors of domestic violence who are petitioning for themselves under the Violence Against Women Act, people who are applying for or who have certain visas for victims of serious crime or human trafficking, and abandoned or abused children granted special immigrant juvenile status, among others, are not subject to public charge. Now, public charge applies at 2 points in a person's immigration journey. First of all, when they are outside the country applying to enter the United States, and that's actually done under parallel rules from the State Department. And then when they apply to adjust status to become a lawful permanent resident, again, that's getting their green card. Once a person has their green card, if they leave the country for 180 days, that's 6 months, they could be assessed for public charge and all the other grounds of inadmissibility when they attempt to return. But otherwise, once a person becomes a permanent resident, they don't have to face a public charge test again. So public charge will not apply when the person applies to become a citizen, renews their green card, it's just the document that expires, not the status, or if they have a marriage-based green card, those people get a conditional permanent resident status for the first 2 years. When they apply to have the conditions removed, there is no public charge test at that point. Okay, talking about what's in the 1999 field guidance, and we have prints here because we're going to party like it's 1999. The guidance incorporates that same totality of circumstances test that is in the law. And again, no one factor can determine whether a person is deemed likely to become a public charge. Positive factors can outweigh negative factors. One of the biggest changes, I should say, is in terms of the benefits that are considered. Under the 2020 rules, things like non-emergency Medicaid for adults and SNAP were considered. Going back to the 1999 guidance, only 2 kinds of benefits can be considered in the public charge test. The first is cash assistance for income maintenance, and I'll explain that more on the next slide. The second is institutionalization for long-term care at government expense. Also, the guidance noted explicitly that people should not be asked to repay the cost of any benefit that they received, because there were some states, including California, who were requiring people to repay benefits prior to 1999. Now, cash assistance for income maintenance is a kind of cash that would be evidence of primary dependence on the government for subsistence, meaning your costs of day-to-day living. So it would be assistance, it is assistance that is intended to pay for the person's ongoing living expenses. So this is TANF in California, it's called CalWorks, CAPI, which is another California state program, which is Cash Assistance for Program for Immigrants, SSI, General Assistance or General Relief, cash assistance from any level of government, federal, state, local, that is intended to cover day-to-day living expenses on an ongoing basis. It does not include cash payments that are earned, like Social Security retirement benefits, or cash that's intended to be a supplement or to pay for a special purpose, like childcare subsidies. It also does not include one-time cash payments like the economic assistance payments that many people have been able to receive through the different COVID-19 relief packages. Long-term care is not short periods of institutionalization for rehabilitation purposes. It is something like a nursing home that's paid for by Medicaid or public residential facilities, such as state homes for people with severe mental illness. I know that with the COVID right now, there are a number of COVID long haulers who have to go into rehabilitation facilities after they exit the hospital. That is an example of a short period of institutionalization for rehabilitation purposes that would not be considered a public benefit under the guidance. Okay, And now let's talk about some other changes in immigration policy. First of all, on the day of the inauguration, the president executed a number of executive orders. Some of these related to immigration. One of them reinstated the DACA program. DACA is Deferred Action for Childhood Arrivals. It's for the young people who came to the country when they were children who met certain educational requirements, passed a background check. Throughout the previous administration, there were some attempts by the government to dismantle DACA. DACA is now back in full effect. So in addition to being able to renew their DACA, people who became eligible for DACA, they became old enough or something in recent years, are able to apply for the first time. The executive order also reinstates something called advanced parole, which was permission to re-enter the country after leaving, which allowed DACA recipients to go back to their home countries, many for the first time since they had come to the US as children. There is still a lawsuit pending in a court in Texas, which is an ongoing threat to DACA, but for now the program is fully back in effect. Now, in addition, there have been several pieces of legislation that were introduced. The Farm Workforce Modernization Act is a bill that was passed by the House of Representatives on March 18th. This is a bill that provides a path to permanent residence and ultimately citizenship for agricultural workers. It creates, first of all, a status called Certified Agricultural Worker Status that provides a period of temporary residency for undocumented workers and their spouses and children if that worker has met a threshold amount of agricultural work. It's at least 6 months over the last 2 years and passes a background check and doesn't have certain criminal convictions, as well as having been continuously present in the US. It also provides a pathway to lawful permanent resident status, again, a green card, for people who have that cause status and meet additional requirements for agricultural work. And it adds employment protections, including rights to shade and water for people who have temporary agricultural work visas like H-2A. A second bill was introduced, but has not yet passed out of the House. This is the Citizenship for Essential Workers Act. It also provides a pathway to lawful permanent resident status for undocumented essential workers who pass a background check. And it includes workers who lost their jobs in essential positions as a result of the COVID-19 pandemic. Essential workers are defined as including agricultural workers, workers in meat, fish, and poultry processing, manufacturing, construction, food, and healthcare workers. There's actually a longer list. A third bill, which did pass out of the House on March 18th, is the Dream and Promise Act. This is the same bill that was passed in the House in 2019, but was not heard in the Senate. And it establishes a pathway to permanent resident status and citizenship for DACA recipients and people who would have been eligible for DACA. In 2019, people were only able to renew DACA because of the legal attacks on the program. So this would probably be amended to be limited to DACA recipients. And then it also provides a pathway to status for people who have temporary protected status and deferred enforced departure. These are two kinds of discretionary relief from immigration enforcement that can be granted to people who are present in the US, and they don't need to be present with documentation, when something happens in their home country that makes it unsafe to return. And I am going to now hand it back over to, I'm not sure if we're going to go directly to Liz or back to Brian.
Hi, folks. This is Liz. I'm happy to go next. Just give me a second to pull up my presentation. Okay. And let's start slideshow. All right. I hope everyone could see that. And if not, please let me know. So my name is Elizabeth Oseguera, and I'm with the California Primary Care Association. Wanted to kind of give a very brief agenda as to the things I'll be covering today in my brief presentation, which is mostly resources. We just wanted to really highlight for you folks what resources are available to you in this space and may be of help as you're thinking about communicating the changes happening in the immigration policy arena to your patients and community members. To start off of, wanted to present California Primary Care Association, who we are, and we are the California PCA, helping to represent throughout the state about 1,366 community health centers. We were founded in 1994 to kind of create a unified statewide voice to represent the needs of health centers and their patients throughout the state, and now also nationally. Just a little bit more about our patients. We see 1 in 6 of our patients are served, who are served by California Health Centers are also Medi-Cal patients. And that equivocates to about 7.4 million patients in total that we see. Regarding the patient mix, as you could see here below in the image, we have primarily we serve Latinos at 53%, but we also see the Black community at 6%, and API at 8%. Regarding non-English speaking patients, we have about 34% of our patient mix are non-English speakers. And we see about 860,000 migratory workers and about 363,000 homeless patients. Wanted to kind of give some background as to why we're kind of bringing this to you today, and I think Gabrielle kind of mentioned this in her presentation, but essentially, we're still battling the chilling effect. It's a great and awesome win on the public charge front that we've been able to kind of struck down the public charge rule from the Trump administration, but now we are still combating the chilling effect, what's left. And that kind of goes into thinking about what is the impact that the policies passed by the Trump administration and kind of everything that happened in those years of anti-immigrant policy really resonating to the top, and that impact to the mental health of our immigrant patients and kind of what happened to their mental health leads to their actions. And if their mental health is, feeling that they're being targeted, that they can't go into the market or can't go take their children to school in a safe manner, then you see them kind of pulling back from society and pulling back from utilizing public services that are really needed by maybe their family and themselves and their community, but yet the fear is keeping them from being able to access. So we want to make sure that we break down that barrier by sharing with you guys some of the resources that may be helpful to you as you are working with your patients in your communities to combat this chilling effect. Which again does really kind of hurt the interpersonal self and then hurts their ability and how they are interacting in our society and with our politics and policies, and kind of just pushing back on things along with us. So here on this slide, I shared 3 fact sheets that were created in kind of response to everything happening today. And the fact sheets are available and linked on this PowerPoint. So if you are able to access this, you could access the different languages for each of these 3 fact sheets. We have it available in English, Spanish, Chinese, Korean, Tagalog, and Vietnamese. And the 3 fact sheets really kind of focus around, 1, the healthcare system and making sure that folks know what healthcare services are available to them, what insurances are available to them, what ACA is, how that may apply to them, Medi-Cal or Medicaid for others. So that's kind of the first one. And of course, we mentioned COVID-19 and reassuring folks that public charge does not impact COVID-19 services, and therefore should feel very safe in acquiring those without fear of being impacted by the public charge rule. The second one is around COVID-19 testing and treatment information, plus information on how to advocate for their own health rights. So that one is very helpful with trying to, we kind of list out if you have questions, making sure that you find an attorney who is very well versed on the public charge rule so that they could help you maintain the public services that you currently have while still adjusting your status or changing your status. And then the third form that we have is free and affordable food for California immigrants. And this one is just talking about kind of the SNAP program. And again, making sure that folks know that it's not impacted by the public charge rule and hopefully they feel safe in using the services. On this screen, you see a snapshot of one of our fact sheets, the Stay Healthy fact sheet. So you could kind of see how we align things. One thing to note here is the public charge assessment tool, which is noted here on the bottom of the Stay Healthy document. This assessment tool was created by the San Mateo Legal Aid in partnership, I believe, now with the National PIF. And they've created this website first for Californians, but now have expanded it to be national website. So really encourage folks, if you are still having patients come to you with concerns on public charge, feel free to use this assessment tool as a way to walk them through kind of what status they're currently in, what status they wish to be in, and the public services that they're using to see whether or not they need to be concerned of the public charge rule. This tool has been updated to reflect the current changes and has been kind of evaluated by attorneys. So I hope that kind of secures and I hope that hopefully creates some safety in using the tool. You could also text or use it via a website. And this is a great tool that our enrollers, I know here in California, health centers have been using and have found very helpful. And this other sheet that you see here, this is just kind of highlighting the different handouts that we have. We also have both community and service provider modules. So please note that you could find those on CPCA's immigration resource page, which is cpca.org/immigration. And here on this slide, just kind of giving you a synopsis of our service provider training modules. Again, all these can be found on our CPCA immigration website, which is again noted here at the bottom of the screen. But you could kind of get a feel as to the different modules that we have. The purpose for this is that really we work with community-based organizations to create trainings for their community members and their service providers. We have different modules for each of the, either if it's a service provider, you'll use what you see here on the screen. If it's a community presentation, we have shorter presentations of 15 minutes and 30 minutes, keeping in mind kind of the audience that we're targeting. If you are doing a service provider module, the hope here is that you could go ahead and look at all our modules and let us know which ones you would like us to present on, and then we'll work with you to get the presenters, make sure that there's an attorney present to kind of help answer those legal type questions. I will say that we've been kind of revamping this given the outcome of the public charge rule to make sure that we reflect that change, of course, but also that we are changing our terminology in the way that we're speaking about the rule. So for example, wanting to speak less about the public charge rule nuances and more about the public services that are available for folks in the hopes of just focusing on kind of access and removing those access barriers and mentioning the public charge as no longer being an access barrier. So just kind of switching our messaging a bit to, again, resonate with the times of today and making sure that we are meeting the moment and helping patients really get to the public services that they need and no longer focusing on the public charge rule nuances. And then here on this slide, I just wanted to present to you all the PowerPoints that we have available for community. Again, we have these available in English and Spanish, and they come shorter. They are, I believe, 15 minutes and 30 minutes to kind of help you be able to take from those as you need to be able to present to community on the public charge matter. And then, as I mentioned, we have the public charge assessment tool, keepyourbenefits.org. Really hope folks do use that. It was created by immigration lawyers and has been vetted to make sure that it's up to par and ready to use given all the changes happening in the public charge arena today. So as I mentioned, we're reapproaching public charge messaging. We want to be very, as you're maybe thinking about taking this to your community, maybe you're thinking about doing a training, or maybe a fact sheet, or just thinking about some talking points that you could reiterate to your staff as they're getting questions. One thing to keep in mind is to be clear and concise. Avoid trying to provide details about the 2019 public charge rule, especially now that it's no longer in effect, and really just focused on access to public services and just explaining what those services are, especially if you live in a community where there's community-specific resources. One of the benefits in partnering with CBOs and local communities to host our trainings is that as part of our MOU, we request that they present on the community resources and community public services that are available to them in their county that may not be available for others in the throughout the state. So this way, folks attending can get information directly about what is available in their community. And again, focus your presentation on public services versus details of the public charge rule to remove the chilling effect and kind of help remove some of the misinformation and misconceptions around the rule. And then share updated statements by state or federal agencies, making it clear that public charge rule is no longer in effect. So for example, HHS put out a statement, so maybe sharing that with folks would be helpful. I know here in California, we are working to do something with our state to make sure that all the COVID-19 resources have some type of language recognizing the public charge rule is no longer in effect and that immigrants can use these services. Highlight that COVID testing, treatment, and vaccines are available regardless of immigration status. I know that us as advocates, we repeat this in various spaces and believe that maybe others have, taken the point very well, or that the information has been received in the way that we wanted it to be received. But we really wanted to say that what we've seen is that it takes about 5 to 9 touch points for someone to really grasp the information you're sharing with them. So I think making sure that in all your resources, you're outlining that, it will be very helpful. Also, for folks who are interested here, we do work in coalition with APSHO and NAC to host a National Health Center Immigration Work Group. We have NILC, Gabrielle Lessard actually, come and speak to us every month and provide us policy changes and updates in the immigration space. We also have guest speakers come and talk to us about different approaches that they have with immigrant populations, including farm workers and migrant workers. So please join us if any of this is of interest to you. This is really a thinking tank where we like to provide updates, share resources, and have all of you share resources with us and share your approach to the work with your own peers. So if you are interested in this and would like to register, we are using a SurveyMonkey link to do that. So feel free to register and we'll be happy to add you to our email list moving forward. And again, if you are looking for any other resources we kind of mentioned today, CPCA's immigration resource page, you have the link there, cpca.org/immigration. We also encourage you to check out Protecting Immigrant Families campaign's website, which is protectimmigrantfamilies.org. They have some great resources, talking points for both advocates, so you and I, and also community members and our patients. So with that, that's the end of my presentation. I'm happy to pass it over to Mary Jo.
Hello, and I'm just going to jump in here really quick. I'm sorry, this is Brian Parrish, the moderator. If we would just take a little time in speaking, it's a little bit difficult for the interpreters to interpret accurately, and they're missing some sessions. So, and there are a lot of acronyms. I think all of us are aware of that in the public health space. So just to make sure that those are interpreted well. So just to clarify, paying mind to interpreters, thank you very much.
Thank you, Brian. This is Mary Joey Barra Vega. Buenos dias, everybody. In true promotora style, I am going to ask if any of you, I know that we have our cameras muted or turned off, but I would ask if you guys, maybe even if they're turned off, if you guys would grab a pen, if it's close to you, and try to balance it on your finger. Mine just fell off of my finger. But just for a second, try to do that and see how that goes. Of course, mine fell, and one of the things that promotoras like to do is when we begin training and talking to individuals is kind of breaking the ice and doing a dinámica, kind of doing an icebreaker, but it's with intent. And the presentation that I'm sharing with you today is called Promotora Outreach, Mitigating Immigration Fears and COVID-19. And the reason we start with the icebreaker primarily is just to kind of break the ice, and it also to introduce us to the topic that we're going to be discussing. And so balancing the pen on your finger, if you could or you couldn't, sometimes you have to practice it. You might have to grab it, or it might fall like mine did before we started. And I think that that's very much like the work that promotoras do in clinic. When we're dealing with issues around immigration and COVID-19. Those fears around both of those topics are super high for us and the populations that we serve. So one of the things I'd like to share with you is this. This is kind of it's a balancing act, the work that we do here at the clinic in our outreach program. It takes three pieces, and we've kind of figured out the balance, but sometimes we get too busy in one area, and so we need to pull it back a little bit so that that pen doesn't go in one direction and kind of things fall apart. So the three areas that we primarily have been focusing on here in Quincy, Washington, is we do outreach in the community, and we'll talk more about that. We also do in-reach inside the clinic and providing services to our patients and clients and our community. And we also do advocacy. Very quickly, I wanted to show you where I live in Quincy, Washington. So for you guys who don't know about Washington State, if you guys were to hold up your left hand and you guys were to roll down your fingers and pull in your thumb, that would kind of be the outline of Washington State. And we are right in the middle. So we're kind of the belly button, the sacred space in Washington. And that's where the majority of H-2A and agricultural workers live in our state. So I just wanted to share a little bit about where I live so you guys can remember that. I'm going to move on to the next one. So in outreach, one of the things we have been doing is doing prevention work, going out and doing prevention talks regarding COVID. And then last year in particular with the pandemic, started to begin to discuss prevention education, and we developed a curriculum that we've been using, and it kind of got the gold star from some of our state directors in different programs, and they're really glad that we were doing that. And it was at that time when the pandemic began, we actually found out as time went on that we were the only ones at one point in our state that were actually doing outreach for community, or in our community, and in particular to workers. So that was a heavy load to carry, and we just kept pushing people. You guys need to get back out there. You need to get back out there. So that finally happened, and so that's been very successful for our population, in particular with the fears that they have about the pandemic. We also have been using social media inside the clinic and outside the clinic. In particular, some of our best work has been using WhatsApp. That's an app that a lot of our immigrant population is very, very good at using. Everybody seems to have it. And it's something I might suggest as a clinic or as a community-based organizations that we begin to use that platform. It's a favorite, and actually it was very, even for myself who low-tech Aztec, can use fairly easy. So I really recommend that maybe that's a path or a place for us to begin to look at doing outreach. We also have been doing pop-up clinics and helping to get vaccine into the arms of our community members. And then of course, this week in Washington, last Wednesday, they opened it up to all ag workers. So we've been super busy coordinating with and navigating workers and orchardists to come into the clinic and get their vaccine. So that's been super important here just recently. I also wanted to mention that we also address food insecurities. I think Liz was talking about that. I think with our population, that's one of the things, because they're not coming in for services or they backed out of getting services. Food was the very first concern that people have had. And so we continue to do a lot more second harvest food, mobile food banks, and we will have blocks and blocks and blocks of people waiting to get food. So that's been very important to our outreach program. Also, we this last winter, we started giving away some of the Washington Immigrant Relief Fund money. So a lot of our population would come in and apply for the $1,000 that was available to them. And I understand that we are going to begin a second round of WRF funds in Washington State. So we'll see if we'll be involved with that piece. These are some of the pictures that I wanted to show you. On the top left screen, we work with mayordomos, or a lot of crew chiefs. The picture in the middle is actually the page for our outreach prevention curriculum that we use. We also work with a lot of women with domestic violence, and there's been a lot more violence and depression with our population because of COVID and immigration fears. At the bottom right-hand corner, I'm out there doing some prevention education talks at one of the orchards with our H2A workers there. And then on the left-hand side, there's a very sweet picture there of some boxes of food that we were giving away from Second Harvest. And this little boy, if you can see him, he actually had asked if he could take a box of food home to his family because they needed it. And he was too small to carry the box. So one of our local fire volunteers carried it all the way through the trailer park and got it to his family. So a very, very sweet little picture there. And in Reach, I'll just kind of review some of these things. We provide access to services for our patients. We connect them to testing and to vaccine just recently, and also sit on different committees doing that piece. Also, we connect with people to local mass vaccine sites, groups like Chelan Douglas Health District and Tu Grupo Café, which is a community-based organization. We also receive, educate, and monitor workers before and after vaccines. So we might get a big bus come in here and we'll work with our team to make sure that they're taken care of with their vaccines. We also do coordination and collect data from growers and then share it to our staff here. So it's a smoother process for everyone involved. I think one of the important things that we also have done here for our clinic is that we really push to have what's called the lunch and learn. And that's where we have a provider, our medical director, who comes and does education for us as staff. I think even us as staff, we're so busy working, sometimes we need to be updated with the latest science and information regarding COVID. So that's been very important to us. And I wanted to show you this document that I was not able to download, but maybe we can get it later. And it's called Myths and Facts. And so the reason I'm showing that to you is because a lot of our H2A workers have lots of fears. My favorite one that I laughed often about is that they're afraid that if they get the vaccine, they'll become zombies. And so we laugh about that, but those are topics that we need to discuss. There's a whole lot more, but maybe I can share that out with you guys later. We also maintain relationships with our providers to, so that if there's any behavioral health consultations that I will do with them, we can kind of keep them up to date, and I kind of augment their work with the work that we do with them. So there's lots of teamwork regarding some of the in-reach that we do. I think the last thing regarding in-reach that's very important is using your staff as promotoras, using them to get information out to their community, to their family members. I could safely say that our clinic has so many wonderful people in it that if I asked them to get a piece of information out by the next day, most of our town would know what would be happening. So that's a good way of using your staff. These are, again, some photos from ¿Qué hago si tengo el coronavirus? So what would I do if I have coronavirus? And we made flyers like this to meet the needs of our community. So we're looking at health literacy levels. There's my mano derecha, Priscilla Tovar. Actually, she used to be my student when she was a junior high student, but has been here close to 10 years and master promotora. And of course, there's lots of information there stacked up. That's one of the pieces of work that we do as InReach is we gather lots of information. Off to your right-hand side, some of the panels that I've been asked to be on and talk about the same issues that we're discussing here with you. Also, there's, doing some of the work that we do is, working with the National Guard and the Second Harvest, giving out, boxes and boxes of food that are so needed right now. And then one of the other things that we do with regards to InReach is really reaching out to some of our partners. Quincy, although we're a farming community, we also are home to some of the biggest global tech, we call them the clouds here in Quincy, like Intuit and Sobe, Yahoo, Microsoft. So they're all in our backyard. So we're a farming community, but also a high-tech industry, or actually high-tech industry lives here in our backyard. It's kind of interesting having them here as well. They're very good partners with us. As far as advocacy is concerned, we do a lot of, we've actually created a phone call with Northwest Regional Primary Care Association and Northwest Justice Project, and we hold a meeting every other week for promotoras who work on the ground and anybody else doing work on the ground with their population. That call has now become a tri-state call, and we do have people who join our calls from other places in the United States where we discuss some of the needs of farm workers and their families. And that's been very successful at moving a lot of the advocacy that we need for farm workers and Latinos and immigrants forward. So absolutely wonderful call. I invite you to participate in that. And then we also work really closely with other community health centers and community-based organizations who do advocacy regarding workers and with workers and immigrants. And then finally, some of the calls and meetings that we have, we attend meetings that discuss testing, vaccine, outreach, promotora supported phone calls. We also write letters when necessary for helping change rules. We also testify when necessary at events, and also serve as subject matter experts to get our point across and support our immigrant and farm worker communities. So we'll use even photojournalists. We have friends who do stories for us and move and push items that we want to talk about. We'll work with attorneys there in the top middle. That case was very instrumental. Ty helped us basically sue a local hospital because they were asking for social security numbers in order to have them receive services. So that went in our direction. So that was great. Off to the bottom right-hand corner, you have our ex-mayor who is always at our events, and we're always working with him and advocating for items that we would like to see in our community that better support our farm workers and immigrants. And then the top left corner, a good friend of mine, Abby, scholar, su servidora in the middle, and then Brenda, who is one of the founders of YSEEN and Washington Immigrant Solidarity Network. Amazing group, and they've actually changed some rules here in Queens in our state to better protect immigrants. And if I had more time, I'd tell you all about it. But amazing group. And I know we're kind of short on time, so I'll just move on to if we have any questions, and if you guys have any comments as well about the work that you do, I'd love to hear it. Thank you.
Great. Thank you, Mary Jo, for that. Very, very great presentation. I know I enjoyed it from this side, from all three of you all. And we do have a couple of questions, it looks like, that came up into the chat. It looks like you all are working to get some of those answered. I think the one question I'm seeing here is, can you link to the public charge handout? Looks like Gabrielle said we'll get the materials out to everyone. So that's nice. And then we have a question about, is that how you contact patients with appointment info in regards to WhatsApp? You mentioned WhatsApp as something your patients and workers use a lot. Is this how you contact patients with appointment info?
So how we used WhatsApp this year is that we were helping our immigrant and undocumented population to access funding, and sometimes because they lived far away and we weren't able to see them in person, we were able to send documents from through WhatsApp. It's a end-to-end phone call, so they were able to send us documents and information that we needed to fill out the documentation for them to receive their $1,000 check. And so we used it in that way, and very easy to work. Even for myself, who's technically challenged. So that worked really good. And older individuals, our indigenous populations were able to maneuver it. So that worked really well. And we're having ongoing conversations now about how do we use WhatsApp in a safe manner that still protects our immigrant and migrant populations and our patients in particular, to make sure that we're not stepping on any HIPAA lies or anything like that. So that's worked out really good.
Great, excellent. Is there any other questions now? It looks like we have still about 5 minutes. And maybe while people are thinking and stimulating the brain a little bit here, I would like to direct everyone's attention to the SurveyMonkey post here. And I just posted this into the chat. So if you would just take a minute to complete this evaluation before you leave, we'd really appreciate the feedback. I would like, folks to maybe identify something that they would remember and use from the presentation, or something that they can do differently, something that they can implement as a result of this session. And so I just encourage you to include this on the Tracking to Success feedback survey. We do have a question that came through. It says, thank you for your presentation. Since migrant and seasonal workers have long hours, what time and day do you find has been good to do outreach at the camp?
So I think for us here at the clinic, we actually do whatever the grower wants, just because we need to appease and make sure that we grow relationships with them. So we'll try to appease them and go out early in the morning if necessary. Usually as it gets colder, gets warmer, we'll do more evening things, so things are done maybe afterwards. But right now, during the pandemic and trying to get the vaccine done, we've been doing a lot of work in the morning. And it's unprecedented, but we started our outreach program in February. There was snow on the ground. And we went out to the camps and did some prevention education and talked about different kinds of vaccines, and got the workers warmed up to accept the vaccine, because they had some fears about that. But I think you do what you can when you can, and that means weekends too. Then we do weekends.
Great, and it looks like Elizabeth has posted as well into the chat the link to their immigration toolkit in English.
Yeah. Yes, and folks could use that link to access the other languages as well. So hope that's helpful. And wondering, Brian, since we still have a couple more minutes left, is there maybe an approach that your health center has taken? And this is to the audience, an approach that your health center has taken to maybe combat the chilling effect that maybe it would be helpful to share with folks here. Just wondering if there's anything or if there's any questions that you've been receiving from your community members or your patients that you don't have a resource for, and that would be helpful to have a resource to kind of help you then message out what you're trying to message out to your patients. So let us know if there's anything like that that would be helpful, because that would help us then know what resources you all need so that we could help produce them.